Okay, so for today, we're gonna go over the specific rhythms. I'll have pictures that kind of go along with it. Talk about, I think I provided you guys definitions on everything. We're just gonna talk about interventions. So it's all in one place together, and then go over the stress test, and then go over some questions. I think there's like 10 questions here, and we should be good to go. And I know we did talk about some of the rhythms a little bit yesterday. Rest yesterday was mostly the basics, but um since I know you guys know some of the stuff we kind of touched a little bit about it. So yeah, so let's start with symptomatic bradycardia.
Yay.
So here definition of that is pretty much just heart rate less than 60 for your bradycardia. Um Yeah, so I guess we can add, what does it mean to be symptomatic? I know we actually did talk about that yesterday, but kind of remind the chat. So what does it mean to be symptomatic?
Unstable.
What does unstable mean?
Dizziness. Diaphoresis.
Mm-hmm. So hypotensive, yeah, hypotensive, alter mental status, yeah, alter level of consciousness, spelled hypotensive wrong. Pretty much not feeling good, low SATO2, maybe shortness of breath. True, most part. You can have chest pain as well. So, all right, cool. So when it comes to symptomatic bradycardia, I will get you guys a picture of the bradycardia so you can kind of just have it in one place here.
Yay.
So let's kind of get it here. So that's kind of what we're looking at here. So we can see, this is kind of a slightly weird looking one, but you can see how um we have a regular R to R, our P's are fine. It's really slow. So what are our interventions for someone that we know is symptomatic? So we talked about before, if someone is bradycardic, but they don't have any of these symptoms, then it's just kind of about monitoring the patient. But if there are symptomatic, so it looks like Josh already talked about it here. So yeah, we're gonna do atropine. So atropine 1 milligram, and it's worth noting that they're able to get up to 3 doses. So up to 3 doses, and this is every 3 to 5 minutes. So that is
Yeah.
correct. Anything else that could be done after atropine? Resuscitation.
Resuscitation.
True. We like that. So if it doesn't work, we can try dopamine or epinephrine. True. What else can be done? Yeah, so that's when they can get the transcutaneous pacemaking, which can be done with the AED pads. That has its own little thing there. Um, Additionally, we can kind of just, function on your ABCs. So the patient has SATO2 that's slow. We can give them some O2, kind of just help some of the symptoms. But the atropine is going to be the first line. And this whole up to 3 doses every 3 to 5 minutes is something you've seen before with like your nitroglycerin. It's something you'll see again with your well, not the up to 3 doses part, but um the every 3 to 5 minutes you see again with the epinephrine. But yeah, this one's pretty basic. All right, we all got that one.
Yeah.
And let me know, Kaylin, if you feel like any of the questions would work in between, um, like part of the way through instead of just doing it at the end.
I was planning to just do it at the end, just so, because otherwise, if I do it right after, it'll be like straight up. How do I say?
I see. It's give them some time to forget.
Ah,
True, true, true.
try to have the information sink in. and retain.
Yeah. All right, so let's talk about symptomatic tachycardia. So kind of again goes with what we were talking about, symptomatic. Just kind of apply this to anything that's symptomatic. Definition is just heart rate above 100, but keep in mind that typically the P wave and the T wave will both be visible. So take a look at this one. Here we can see the R to R is consistent, but it's happening pretty fast. So I'm assuming this is a 60-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Like 100, about 140 is a defined treating underlying cause. Yes. So symptomatic prevention, symptomatic, not symptomatic, treat underlying symptoms. In general, that's going to be some of the things you can do with it. So a lot of the time, the with the tachycardia, symptomatic tachycardia, it is a lot about just kind of assessing and treating the issue. So let me see what else I can do. So what does that kind of involve? And I know we're talking about adenosine here with Josh. Usually for like SVT, for symptomatic tachycardia, I'm not so sure if
My
they
bad. I thought we were on SVT for some reason.
uh
Symptomatic tachycardia, it's more about the treating the cause as opposed to using medications. It wouldn't surprise me if you could,
uh
um, but it would typically be another medication first.
yeah, so let me see what else was mentioned. So things that could
My
be
bad.
causing it. Yeah, so something that could be done is giving them oxygen supplementation, fluids, reduce fevers, fluid replacement for sure. Um, anything that fixing electrolyte imbalance. Yeah, so like if they're having like medications or they're doing things, stopping whatever meds could be causing it. Stopping or withholding is probably a better word. Withholding medications or substances that may be responsible. Give them, sure, like to monitor their, so that's something that could be do. So monitor rhythm. So that's where the EKG can come in. Symptomatic vagal stimulation. I mean, that's sure that's what they say for SVT, but it should be the same kind of idea still. Because the vagal stimulation is technically going to be something that causes a decrease in heart rate, so it should technically still work if you really want to. Like, I don't see, yeah, for
More for
SVT,
SVT.
more for SVT, but technically it should also work because I
I
know
think
that the vagal you can stimulate your vagal for anxiety, and anxiety can be a cause for sinus tach. Um,
think that the reason why it wasn't mentioned, because I don't think it's anywhere in our personal notes. I think the reason why it wasn't mentioned because it could be very easily confused with SVT, um, where it's more used. I think there was just it wasn't mentioned for tachycardia just to prevent confusion, but it wouldn't surprise me if you could technically use it as well.
yeah, like if you're anxious, that's something you can do. You could do the vagal response. You can do stimulating the diver's reflex. So you put cold water on your nose, like your nose
Oh,
area, and that stimulates the body to think it's underwater, and it will um kind of kind of like the vagal response. Similarly, drop blood pressure, drop your heart rate. So for my anxiety people, that helps. Um, can also try like beta blockers because that's something that and again, this is also another thing that can be done with anxiety. So you can get um, beta blockers as an anxiety med as well. That helps with, and in general, we know how it affects the heart rate, so that's something that can be done uh, with the tachy. Let's say same as SVT. Honestly, yeah, it will be pretty much the same because at the end of the day, it's gonna a lot of the stuff that works for SVT works with slowing down the heart rate, so it should be a lot of the same stuff. Maybe the one that might not work the same would be the amiodarone drip because the amiodarone drip is about it is more to do with like arrhythmias, while sinus tachy is technically just a fast heart rate without uh any abnormality in the pathway. So it'd be more, I would say more about the vagal stimulation and the and whatnot. And then adenosine might be too extra uh um for this one. Yeah, amiodarone for AFib or BFib, but amiodarone can technically for SVT can be done for like as a drip, but for the most part, it's mostly for the for those, and then VTAC as well. But yeah, pretty pretty good on that. Anything else that we have? Reduce fever, anxiety, beta blockers, withholding anything that may be there, fluid replacement. Another possible cause of tachycardia would be pain. So pain relief could be something that helps with the sinus tachy because for pain, our vital signs go up. Same thing with the anxiety. All right. So we good so far? Cool
Yes, thank
beans.
you.
Cool beans. So now atrial fibrillation. So let's take a look at that looks like here. So AFib. Boom, boom. Oh, that's not AFib. This is AFib. Okay, so this picture here, you can kind of see it's not the best quality picture, but uh, okay, not the best quality picture, but you can see how it's got some of that fibrillating. You can't really see the P wave. It's just a bunch of like fibrillating. Yeah, so that's one of the telltale signs of atrial fibrillation. I'll see if I can get a better picture. But yeah, definition is that irregular ventricular heart rate. So we have those QRS spikes at seemingly random times as opposed to something else, which could be like regularly irregular. So like it's irregular at expected times. Here it could be irregular at wherever it decides to fire off at. But technically the atrial rate is really high, but again, you can't really measure the P to P. And this is one of the well, you'd be able to tell based on the fibrillations, but also we can see here that it's not really matching the R to R. It doesn't, you can see very much here. And there is something with AFib that you need to watch out for, in that interventions to use that diazem, correct? So let me see if I can get you a better EKG scan. This one's kind of tiny, kind of low quality. This one seems better if it lets me. So let us replace with this one, a little bit higher quality, and you can still see a little fibrillations. Yes, so all right. And then see if I can add on anything else. So cause of stroke, yeah. So that is something that you want to keep in mind. So let's kind of split things up into like a stable AFib versus unstable AFib. So usually the unstable AFib, you can think of it like AFib with RVR, RVR referring to rapid ventricular rate, meaning that this rate,
Heart rate fast.
yeah, the heart rate goes really fast. So a heart rate of like about over 100. So an abnormal heart rate with your AFib, that would be an unstable AFib. While a stable AFib, the patient is within a normal ventricular rate. No, your normal heart rate essentially. Stable, we're going, yeah. So what else can you do with stable? So Josh kind of already touched on it, but one of your major complications with AFib is the risk that you can have a stroke. You can have those clots build up in the heart that then get that kind of stay behind and then get fired off. And speaking of that, Kaylin has some other information from being
What?
in the heart in the telemetry unit, like the very dedicated telemetry unit when it comes to AFib.
What
So
did I do?
so in terms of like cabbage and in terms of not defibrillation, cardioversion, if that goes in particular with AFib.
But I'm doing what now?
Explain.
You confused me. What am I explaining?
AFib and its relationship with a cat like heart surgeries, cabbage, and AFib relationship. Things to watch out for with doing like the synchronized cardioversion.
I actually just I was about to put that question in the chat. I was writing the question as you were as you were mentioning my name. That's why I was
No,
like, oh, I don't know what's going on.
no. In that case, ask it and see if people can logic it out as I start adding some stuff and some information down from what we
Yeah,
already
the
talked
first
about.
question I was going to put was if you were to do a synchronized cardio version, what are some considerations and actions that you should be doing before? So definitely take some vital signs. I like it. What else we got? I like it because so. Anything else? Ask about drugs. I'm sorry, I just like the way that was said. Ask about drugs. Sure, we could ask about some kind of stimulant usage as well. That's fine. Because it wouldn't surprise me if that could end up causing um that rhythm to pop up. I'll ask another question. If I had AFib for greater than 48 hours, like let's say it was a new onset for me, what what other intervention should I be doing before cardioversion at that point? They need anticoags therapy. A lot of times, on the floor, we usually have patients where their past medical history already involved AFib, but there are times um, when your patients have new onset AFib for whatever reason. Who knows? Could be several things. Like we have causes acute pericarditis here, hyperthyroidism, and the like. So it could be a very short-term thing just due to their condition. If their AFib has been present for over 48 hours, it's very likely that there is a clot up in there. So before you cardiovert them, you need to start them on some kind of anticoagulation therapy because as soon as we do cardiovert them back, or as soon as they do convert into a regular rhythm, there is a chance that that clot can go straight up to the brain. And that's why you also need to be monitoring your mental status for these patients, watching for any kind of confusion. But then we need to educate them on hemorrhagic stroke risk now and not just embolic strokes before we send them home. I mean, fair.
True.
These
Yeah.
patients, they're more at risk for embolic, but hemorrhagic is something that could technically happen as well. The signs and symptoms for general statements here, the initial signs and symptoms will be similar. Your hemorrhagic will just be significantly worse. I mean, they're technically on blood thinner. A lot of them nowadays are going on Eliquis, which is a very expensive
Hmm.
medication. Before, a lot of your patients were on Coumadin or warfarin, and your Coumadin, you would have to do. They had like Coumadin clinics. Like my mom works right next to one, and you have the patients going in there maybe once a week, once every 2 weeks, however frequency that they have. It's pretty frequent though, to get their labs drawn to check their INR to make sure that they're clotting okay. Your Eliquis, I don't want to say that there's not as much risk per se of bleeding out. Oh, I guess I will say it. I feel like for your Eliquis, it's not as much of a risk of it as opposed to your other typical anticoagulation therapy. Yeah, that's the word I was looking for. It's lower risk. That's the word. That's the phrase. Thank you so much.
Yeah.
Yeah, definitely not like Coumadin. It works on a different factor of the coagulation cascade um to help with clot stuff. But beside that, if I am awake and conscious, I have hyperthyroidism and I went into AFib, and you walk into my room and you say, we're going to shock you, quite literally shock you, and synchronize cardiovert you back into a normal rhythm. Am I gonna like that? Hope not.
Mm-hmm.
If some of y'all do, I'm worried about you. But I you should not should not like that. I mean, this could be considered quite painful. I mean, our synchronized cardioversion, it's quite a lot of joules that we're putting into them still. So if you have the time, if the patient is relatively stable, they're awake, they're conscious, they're talking to you, and you need to cardiovert them, at that point, consider the use of sedation as well. Because I don't want to be awake when you shock me. I'm personally okay. Put me to sleep, please.
Yeah. And then even adding on to that, how does AFib contribute to stroke?
Oh, I guess I never went over that.
Hmm. So would you agree that maybe a clot, if they're not taking anticoagulant therapy, a clot could build up, and then when they have um kind of those like eventual QRS happenings, it could push the clot and then cause a stroke. Yeah. So if someone is having a new onset of AFib, so let's say they had a cabbage, they had some other heart surgery, and they develop AFib, which is something that um, tends to happen, that can happen. If they were to then go be fast and symptomatic after having AFib now for a few days, what is something that you think could happen after doing a synchronized cardioversion on that new onset AFib patient?
We talked about it already, no?
Kind of. S- Essentially, yeah, you could give them a stroke. You could essentially during that time that they were, because like we mentioned here, if it lasts longer than 48 hours, anti-coag therapy. But in that time beforehand, um, where they're not taking anticoagulant therapy and they have AFib, that clot could start to build. And then if they become fast and symptomatic and you do that synchronized shock to get them back, that shock could then dislodge the clot and then you can give them a stroke that way. So that could be potential contraindication, I suppose, for that. Anything you want to add on to that, Kaylin?
Not that I'm aware of. I thought I talked about it already, but I guess I forgot. I think the last thing I'll say is your surgery that's associated with AFib is your cabbage. They're going in quite big major things, and this can cause a lot of like cardiac irritability. So a lot of times after your cabbage, there's a large percentage of them, well, larger than what you would expect. I believe 40% post-op.
Mm-hmm.
It could be up to 40% post-op develop AFib after their cabbage surgery. So just something to be aware of. It's quite a lot. I just looked up the percentage because I was like, I was curious. Studies show between 20 to 40% develop AFib after their cabbage. So quite a lot. There's a lot of cardiac irritability going on there. So something to be aware of, and this will probably be a chronic AFib for these patients. I don't think there's much hope of cardioverting those back, unfortunately.
But yeah, so if you do have that patient with AFib, which you may or may not have for simulation lab, I think you do, but maybe you don't. I think you do though. Then it's worth looking at um, that risk of stroke when it comes to the patient, assessing like their mental status and whatnot, checking their heart rhythm to see if they go into RVR or some sort of other arrhythmia, signs of unstable hemodynamic instability, and then knowing your interventions. And then here I also included that you can do an amiodarone drip as well for the person. So they already, when they're sent home, can take amiodarone PO. So this person can also get it as a drip if they're having that unstable AFib.
I think a lot of times they're sent home with cardizem, though.
That is the Tiazim.
Still thiazum,
Yeah.
which it's another calcium channel, but
Yeah, I'm in terms of the dosing, I believe the 300
ooh,
I think is for one of the other conditions, and then it has different doses for depending on the condition, I believe. So
uh,
I believe the 300 would be for your
VTAC.
cardiac arrest algorithm. Yeah, your VTAC.
Oh, pulsus VTAC.
Yeah. But yeah, any questions on what's going on here with the AFib? Yeah, the defining features of AFib is, of course, this fibrillating and an irregular R wave, or R to R, rather. Okay, cool, cool, cool. So now we have SVT, which I can get a picture of here. Boom. Oop, how did that happen?
Or NAR.
Oh, why is it doing that? Okay, that's better.
I don't know what you did, but good job.
Here's a picture of it. It's not the prettiest. But you can kind of see from this picture here, that we have a regular R to R, but you also notice that the P waves are typically either going to be hidden in the QRS or they're going to be kind of hidden in the T wave. So you can't really see a P and a T, a well-defined P and a T wave. It kind of just looked like it's one thing. And I think the one day that Robin shows in class looks even more is even faster, so it looks even more um difficult to tell apart if you even can because of the way it's set up. So let me see. Yeah, pretty much similar interventions. Let me see if I can find some more pictures. So you'll see it kind of looks like this. Um, um, this one. It's another one, but this one should be fine. I'll just get that one. Okay. Um, Interventions for this one. We mentioned adenosine. So the adenosine can be used to work with that. But let's try to split it off. I know we did talk about this a little bit, but let's split it off between stable and unstable again. So when we have a stable person, what is your first response to that? And Josh mentioned the adenosine, so we'll put adenosine. It can go in both, but what is your first? If someone has like a stable one, then what do we want to do with it? Yeah, so I like the idea of monitoring and using the bagel response. So bagel response, what would be like some examples of what you would tell the person for the bagel response? Transcutaneous, transcutaneous pacing with that one. Yeah,
Transcutaneous pacing for SVT.
that's what he says. Yeah, honestly, yeah, act like you're taking a poop is a good one. So bearing down.
I don't think the transcutaneous pacing is typically more for when they're Brady, unable to maintain their cardiac output from that. I don't recall if they have it for SVT.
I don't recall it either.
I don't see it in our notes personally.
Yeah, I like to blow through the straw, pretend like you're blowing out a candle, coughing.
Take a dump, take a
Essentially,
pee.
intentionally kind of like the pursed lip breathing, if anything.
I was very lucky and I got to see the one day I went to the ER, I saw someone convert SVT back into NSR. So the first thing they tried, because the patient was alert, they were symptomatic, but they were alert enough to follow instructions. They took like a saline flush, empty that out, and they gave it to them and said, like, blow into this as hard as you can, with the hope that bearing down, whether you're blowing through a straw, coughing, taking a dump, you just went to Taco Bell.
Hmm.
Because let's be real. Actually, maybe you won't be bearing down as much if you went to Taco Bell. Maybe the opposite.
Ooh.
I don't know. But with the hope that you will vagal down. So that this person unfortunately did not convert back. So then they had to push adenosine, which
Hmm.
if you see that, there's some interesting things that you'll see on your EKG when you do push adenosine.
Does anyone know when you push adenosine? Yeah, it stops the heart. So they go asystole, and then you're just kind of waiting for it to come back, and then just holding your
It's
breath.
like those like 5 seconds worth are the longest little bits of my life. I was like, are you coming back?
And
Hello?
how fast do you push adenosine?
Ooh,
Yeah, you got to go fast, fast. You just go whoop.
slam it. No, don't slam it. I'll slam it reasonably, right? Like
Yeah, you kind of do.
you guys did your CPE already, right? For IB? Because I know that they try to push a bit more of the critical thinking questions for you guys. So one of the questions that I had gotten in mind was, how fast should I be pushing certain things? Oh, you did a card exam one. Fun. I can't remember what I did. I think I got the jocks. I
Dip-
don't remember.
I did pantoprazole.
You did do pantoprazole. You had to reconstitute.
Uh-huh.
Ha. Morphine. In over 5 minutes. At that point, you just strike up a conversation, right? What was I
Maybe
talking about?
it's 5 minutes in the book. Or we're talking about
Oh,
morphine. Oh, the morphine,
I
yeah.
remember. Bro, I don't know why. I got so many critical thinking questions. She
Hmm.
kept asking me questions. I was like, wait, I'm just trying to do the skill. So one of the questions I got was, if this patient was to code, she gave me a patient that was like 80 something year old dude that was kind of frail looking. And she asked me if this person was to code and like if I was to push epi, how fast would I push it? And in my head, I was like the same thing. I was like, ASAP? Like, I don't know. And she's like, well, what are some considerations for these types of patients? So, we want to maintain the patency of our lines and whatnot. Epi is also kind of a slam.
Hmm.
Um, but yeah, but for certain patients, like if you have a smaller cannula, so if you had a 22 gauge or a 24 gauge in the person's thumb, that's a lot different than if you had an 18 gauge in the up somewhere in the forearm or higher, you know? So considering the amount of pressure you're putting in, you could destroy your IV access. You could blow their vein, very possibly. So we have to consider a few different factors for this, right? We need to consider the size of the cannula, the size of the IV that's there, how much are we pushing, how much medication are we pushing in, and the status of our patient. Are they some weaker veins, or are they big, juicy, and thick with three C's? That reminds me, we always do the smallest for what we have to give, right? Yeah, I mean, I would prefer that. I don't want someone coming up to me and being like, we're gonna put an in you because we want to torture you. Yeah. Because we just want to torture you. No. I mean, you'll try to get in a 20 if you can, but I feel like on the floor I only see 20 and 22, but I feel like I see 22 more. On regular floors, I think I saw 22 more. Because that was acceptable for what's going on most of the time,
Hmm.
right? If I expect somebody to go downhill, I'm going to attempt to give them a bigger gauge. If they came in from an MVA and they're in my ER bleeding out, I want to put the biggest size I can in them, whatever I can manage. Um, so yeah, just a couple things to consider when you are doing your ACLS. algorithms, or if he does do the class with you guys, the ACLS class, or if you get your certification after school, you could also get it during school. Um, just some things to consider if you're going to be pushing medication to make sure that you don't ruin your IV access. Oh, right, you did blood on Monday. Forgot about that.
Oh, nice.
Yeah, so
True.
that you see that 220 gauge came in handy. I'm not sure how long he was there, but maybe it was expected that he was going to need blood or maybe a lot of fluid. So the 20 gauge insertion makes sense. Pink and blue are our friends in general med surg floors. That's cute. I
Yeah.
like it.
And now tell me what is your, when it comes to adenosine, what's your first dose? 6. And your second dose? Yep. Cool. So keep in mind the doses, because I think he already did this to you guys as well during the in class where an answer was wrong because it was the wrong dose. So just keep in mind the doses. He does like to do that along with he loves like giving the wrong type of like giving like a patient that needs insulin IV and then being like, yes, you're gonna give MPH IV, is that correct? And then, so stuff like that.
Aw.
That's his
It's
favorite.
correct if you don't like your
Yeah,
license.
and then he likes Mucomist for yeah, he just like I don't think he tested much on it, but he definitely liked talking about it. It's his favorite. That's his favorite one. He really he yeah, he loves it. I don't know why, but he loves it. And then here I just have
Missed.
a little section for triggers. So your SBT could be triggered by stress, hypoxia, infection. Um yeah, so once you guys get to sepsis, you'll see that there's like a connection between like a big inflammatory response and the release of the your natural release of epinephrine or epinephrine, and a lot of that together can cause your sympathetic nervous system to go up, and then that can cause dysrhythmias and stuff. So together, and then of course the thing to always think about when it comes to the when it comes to fast and symptomatic is your synchronized cardioversion. So you're gonna definitely remember that because it's gonna come up. And then technically with this one, he did mention in lecture that you can do kind of like an amiodarone drip as well with this one. Although my professor that works in the trauma center says she's never seen amiodarone for SVT. It's just adenosine and bearing down and cardioversion. But yeah, that was in lecture, so that'll be there for now. But for the most part, yeah, just make sure you know your doses for this one. Let me see if there's anything else here that could be utilized. Definitely know your atropine, what your dose is, your epinephrine when we get down to it. And then we have, yeah, exactly. Well, both are 1 milligram. We have ventricular tachycardia, and this is what you're typically gonna see right here. There are other types of VTAC that you're not really tested on, but if this is like a monomorphic sustained, then this is what a monomorphic unsustained looks like, but you don't have to worry about that. You're really just gonna see the very basics. So remember that tombstone. Yeah, and there's Torsatz points, which is not tested on, so don't even worry about that one. But here, the definition that I put here is you have a wide QRS. So remember how we talked about that QRS should be less than 3 small squares. You can see here very much that this is much bigger than 3 small squares. So we know that there's something off with the ventricular function. So that white QRS, no P wave very clearly, and it has that sawtooth or a tombstone pattern.
Tombstone.
Yeah, I like the tombstone. Yep. This is one where like it's pretty immediately obvious, so you don't have to bother too much trying to figure out like all the little, like you can tell right away with some of these rhythms just from looking at it what they are. So this one's very distinctive. The AFib can be pretty distinctive as well because of the fibrillation waves. So it involves a little bit less of trying to figure out. But here, we do have kind of like a with a pulse, without a pulse, and with a pulse, you can have that stable but maybe symptomatic kind of thing. But in general, with the pulse, what are some things you want to do with ventricular tachycardia while they still have a pulse? Love that. Love the 12 lead EKG. Adenosine can be something that can be done. So with those fast heart rates, adenosine, and we know that it's going to be 6 milligrams IV push, then 12 milligrams. Oxygen, yeah. So O2 supplementation, if it's appropriate. And yeah, amiodarone as well. So amiodarone. So similar kind of dosing as the other, is like 150 over 10 minutes, and then it's an IV drip. And yes, so if they are fast and symptomatic, then we are doing synchronized cardioversion. And now let's talk about your without a pulse. When you don't have a pulse, what are your options here? Yeah, we're going to be doing CPR. So let's say you have this patient, they don't have a pulse, you begin CPR, get someone to get the AED. Yeah, we're going to want to defibrillate. Um, and what comes after that? So let's say we've done 2 minutes of CPR, we've defibrillated, we're going to do another 2 minutes of CPR, check the rhythm, still pulseless VTach, defibrillate again. What's our next medication? So Josh mentioned the epinephrine, so that's correct. So we're going to give 1 milligram of epinephrine, and then we're going to go ahead and do another round of CPR and defibrillation. What comes after that? So after the second shock, we give epinephrine. After the third shock, sure, consider the airway. What about just medication for now? Amiodarone or potentially lidocaine? So because both epinephrine and amiodarone are after the third shock, yeah. So are like Q 3 to 5 minutes. They kind of go back and forth. Epinephrine and then while epinephrine still in cool down, they give amiodarone and then hopefully yeah treat the H and T's. Try to see what you can do to convert that rhythm. So I kind of have some of the stuff here. We're considering your H and T's that we talked about before for potential causes, and then you get to look at that. Um, what can be done to treat the underlying cause. So again, keep in mind that with your pulseless algorithm, it's 300 milligrams as opposed to the 150 that is done for the other drips. The other conditions is 150 and then drip. The other one's 150 and then drip. This one specifically 300 and IV push 300. Don't worry too much about the lidocaine. Focus more on the amiodarone, I would say, but just know that it's an option. So typically just epinephrine 1 milligram and your amiodarone 300 milligram, and then kind of continue this pattern here. So something I have written down is that after again we talked about like what you can do after the return of spontaneous circulation. So follow that. So the targeted temperature management, um, as well as your other interventions like the EEG, the CT head, fluids, oxygen, exactly. And then here also listed is like potentially give them like a permanent pacemaker or an AICD So because they're at risk of having another uh, arrhythmia leading to cardiac arrest. Okay. Does everything make sense when it comes to VTAC? Pulseless versus pulse. Because then we can move on to ventricular fibrillation, which has the exact same interventions. These are both part of your big cardiac arrest algorithm. So both ventricular fibrillation and pulseless VTAC go on that left side of the algorithm, follow the exact same steps. And we'll take a look at this, and I'll show you I'll show you like a coarse VFib and a fine VFib. But keep in mind for the test, it'll be very obvious if something is um, asystole or fine BFib, because I know, like for the course, it's very obvious that it's coarse BFib. With this one, you could make the argument that you can make the argument that this is asystole. It's very close because it's not always fully flatline for asystole. Yeah, very close,
Close
like
to it.
very close to it. Just keep in mind that asystole might look slightly like this. It doesn't have to be fully flatline, so you can confuse the fine BFib and the asystole. But for the most part, it should be pretty obvious on the test. Okay. But yeah, definition of this is a big fibrillating mess, pretty much. It's just kind of what it is, just a big little mess here. Follows the same interventions as your pulseless VTAC. Any questions on this other before we move on to the AV blocks? Anything talked about here? Boop, boop, boop. I think I added this here, but I don't even think I added anything really that's extra. All right, seems like we're all pretty good on that. I think for all the other ones, I wrote the definition. For these, I just wanted to make sure that you guys knew the definition. So, what is the definition of a first degree AV block? So it does have um, this does in fact have a regular ventricular rate. What is a defining feature of a first degree AV block? Yeah. So in particular, it would be like a PR, the PR interval in particular is prolonged. So prolonged PR interval, which would be something that is above, yeah, 3 to 5 small squares, so above 0.2 seconds slash more than 5 small squares. So that would be your prolonged PR interval, but it's consistent. So it stays at that prolonged um, manner. So let's see if I can get you guys a picture of this. This one's gonna look a little weird just because the lead makes the QRS upside down. But you can see how the PR interval is increased. Maybe this is not the best one. I'll see if I can get a different one.
Did you
This
say
one's
you're getting a better picture? That one looks pretty solid.
I like
Focus, look,
this.
you could see it. Look
No,
at your P. Wait, okay.
no.
Okay. Wait, that
Look at
one's good. That
look
one's
at this
better.
one. See?
Okay. Okay. Why are
Oh, let me
somebody saying
sorry, should be here. That's a good picture. You can see very clearly the very elongated PR interval
Jesus?
there.
That's a that's an interval, all right.
Uh-huh. So what do you do about a first degree AV block?
Cry. No, don't cry.
You never do nothing on the NCLEX. You always do something. Yeah, there you go.
Monitor. Yeah. Get that happen.
Yeah, pretty much just monitor. Be like, cool story. Let me make sure you're good, but cool.
Full story, bruh.
Yeah, cool story, bro. Yeah. It's just really about monitoring. There's not much else you can particularly do. It's typically asymptomatic.
Asymptomatic, but if it is symptomatic, we have to consider, is there, like, if it is
Yeah.
asymptomatic, is there anything that caused it?
Mm-hmm.
Is this like possibly a reversible thing? Who knows? Yeah, DC if they're causing a problem. Because some medications can inadvertently cause the PR elongation.
Yep. Yeah, so that's something that you can do as well. But
I
that's
like it, Picasso.
pretty basic. If I recall the first EKG test, and I believe he told you this probably, uh, is that it's gonna be more the first quiz you have with the EKG is more basic. So I don't think you get tested on anything other past first degree, but everything past first degree will like these ones will come up in the final. So just keep that in mind.
Oh, some maybe 3-second strips. But yeah, you could always clarify with him tomorrow, you guys have? Yeah, tomorrow lecture. Could always clarify with him what to expect. If he would go, if he's gonna go over it tomorrow, you can ask about what kind of blocks you're likely to see as well, just to clarify. What? Oh, I thought, wait, what's
He
today?
has
Wednesday?
oh maybe it's asymptomatic. Oh, you changed it.
Oh, okay.
He said Diego and Kalen got it.
Oh, the AAA and cardio lecture asynchronous. Okay, so like the inflammatories. Okay. Well, crud, that's the outline I'm gonna do this upcoming week. Yay! Fun.
Yay.
Happy, happy joy.
So yeah, pretty basic on the first degree AP block. Now let's talk about these two. So we have Mobitz type 1, otherwise known as Winky Bach,
Winky back.
and then Mobitz type 2. So what is Mobitz type 1? What is Winky Bach? What defines Winky Bach before I post a picture of it?
Oh, by the way, Diego, after you're done with the AV blocks, I put the heart block poem in the bottom.
Cool. I was assuming you were gonna go over it like here, but makes
Yeah, I was
yeah,
planning to, but
yeah.
I have it for all of them. So there's like a rhyme for each. So progression and increase of length
Yep.
of the PR until there's a drop QRS, exactly.
Yep.
So you'll see the that PR interval get bigger and bigger and bigger until all of a sudden you see your P wave that's not followed by a QRS complex.
Yeah, so we can see
So she
here.
failed. She failed.
We can see here this PR interval pretty short. This one's longer. This one's longer. This one's dropped. You see here a T wave, P, no QRS. Another P wave here. So longer, drop.
Wow.
And yeah, another defining trait of this is that it is irregular because you can see with the drops it causes this to no longer match up. So the second degree AV blocks are the ones that are irregular, while first and third are have regular ventricular rates. So let me see what I can write about here. Boom. So PR interval keeps increasing until there's a P wave with a drop QRS, and then this pattern repeats. So it goes back to that same repeating pattern. So what is there to do with a Winky Bach?
Pray, pray, do nothing. I love that answer. Do nothing. It was just funny to me. I'm sorry.
I like the one where it's like, should I get a chaplain to pray for you?
Should I get a chaplain? I mean, I guess that's good looking for, spiritual wellness. Pop off.
So yeah, if it's a result of a medication, then yeah, discontinuing if they're symptomatic, they have a result of a med. I think that's definitely a good idea. Typically, it can be asymptomatic, but when they are symptomatic, what does this lead to? So we see these dropped, we see this dropped QRS. What can you see with the pattern, or like what can you imagine happening with the heart rate? Oh yeah, cool. So Ryan mentioned bradycardia. Yeah, so you can have bradycardia from the dropped QRSs. So
Oh,
in which case you incorporate, you go back up and incorporate your bradycardia protocol. So that includes the atropine, the right there. The atropine, transcutaneous pacing, and whatnot. The patient then, if they're pretty consistent on that, they might have to have a pacemaker, but that's if it's symptomatic. So we'll include this here. All right. So what separates type 1 from type 2? So what's the difference between, what's the definition of type 2? Okay. What about type 2? Mobitz type 2.
terror.
How would you define this one? Yeah, irregular ventricular rate. I'll add this to this one too.
Is it really as often as every other?
It
Probably
can
not.
be, yeah. Yeah.
Oh wow,
So
that
type
sucks.
type 2 is more serious than type 1
Oh, it definitely more serious.
because of how often it happens.
I I don't I just don't think I considered how often it could happen.
Yeah, so every other beat, potentially every other beat. What about the PR interval? Tell me about the PR interval. Yeah. So it will be consistent, either consistently normal or consistently prolonged, but you do have those constant QRS drops. And kind of follows the same idea here. If it's symptomatic, follow the bradycardia protocol. More serious than type 1, it can become a third degree block. The QRS could be narrow or it could be wide as well. So at this point, um, let me get you a picture of it. Here and here it doesn't have the wide QRS, but you can see here um, how the P wave, the PR interval looks like it's normal, but it's gonna be consistently so. But you have dropped QRS, goes back to normal here, dropped QRS, back to normal, dropped QRS. So 1, 2, 3, 4, 5, 6, 7, I don't know, is this even a 6-second strip? I don't know, but yeah, that is the definition. Oh, this should be here instead. And then when it comes to interventions, really it's just, again, it's just follow the bradycardia protocol. But yeah, it is more serious. You'll probably be more likely to be symptomatic. Okay, and then the last of the AV blocks, what is the definition of a third degree AV block? Yeah, so that's exactly what defines the third one, is that you're going to have regular ventricular rate and regular atrial rate, but they will not be in sync. So they will not be relevant to each other. They are working independently. ba. And keep in mind that sometimes the P waves can be hidden under the T or R waves. So sometimes it might look like it's a dropped P wave or something, but it's just kind of hiding inside one of the other ones. So let's take a look at the example I have here. So here we can see, let's just kind of know that. It's gonna go, I guess here it'd be hidden here. Then it's hidden in here. Then it's hidden in the T. I'm not sure why there's a drops there, but unless that's a T wave, that's probably a T wave. So let's just kind of start here. Unless no, I'm not sure why that's there.
Oh.
Let me see if I can get a different picture. Ba, 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 ba. Let's see. But yeah, that's kind of the concept with that. So they are the R to R is consistent with itself. The P to P is consistent with itself. So there's another one here. And of course, there's more rhythms than what you've seen so far, but this is what you get here. So here we have the R's are consistent. Let's just start at this P because it's a little bit easier. Boom, boom. And like I guess the other one kind of highlights how you can have those P waves kind of lost in the T waves because sometimes you have some like strange overlapping
Lost
where
in the sauce.
yeah, it gets lost in the sauce of the T or the R wave. And just so that we're not just constantly repeating ourselves, same kind of concept for the interventions is just if symptomatic, bradycardia protocol, so all the same stuff. Um, but I guess the important thing is that with these people, the atropine is not going to be as effective and they probably will need a pacemaker. Yeah. So pretty much, yeah, everything Josh said there is correct. So again, just refer back to what we had about bradycardia up above. Okay. Any questions on anything we have so far? All right. And then with these, let's just kind of show the picture first and get what we have here. So the premature atrial complex PACs are atrial discharge before the next SA node impulse, leading to an early P wave that gets lost in the T wave. Basically, it's a, a premature P that leads to a premature QRS. So here, I believe it's the smiley face every time you have a PAC. And something that I find interesting in a lot of the strips that have PACs is that the P wave will look kind of peaked. So if we kind of zoom in a little bit on this one, this is
Oh,
the P wave, P wave, P wave, P wave, P wave, and then the PAC P wave is kind of a peak.
dang. It do be kind of tall.
Yeah. So that's just something I noticed. And go back to here. See, yeah, palpitation side effects, if occasionally not harmful, no treatment is needed. That is correct. It's something that I think you guys might be asked, and I think something I think he had an anecdote about is how um is kind of like some of the stuff that can lead to PACs. I don't know if he mentioned his anecdote. He was referring to not to him doing cocaine, but him
What?
drinking a lot of coffee, a lot of coffee.
Oh, I mean, Adderall too can technically cause
Yeah,
that. Oh, you got the triad right there. Mm-mm. Mm-mm.
yeah. So yeah, cocaine, coffee, Adderall, the smart juice.
It's more juice.
So here I
Stimulating
wrote,
things.
I think this was just for me. It's not, I don't think it's emphasized too hard, so I'll change that to this color. So frequent PACs can cause paroxysmal SVT, AFib, which I think makes sense. So you have if you have consistent like premature atrial um impulses, it makes sense. It kind of goes with the AFib. But your main thing here for sure is correcting the underlying cause. So you might have like a question where the person has PACs and like what is your education? And maybe we find out the patient drinks like 7 cups of coffee a day or something. So like a lot of the caffeine. So get a lot of water to flush the caffeine. Stop smoking, stop doing cocaine. You can't-
Not a
Um,
lot of Coke,
yeah.
but Diet Coke's okay.
Like, sir, I'm gonna have to confiscate that.
Stop smoking crack.
Yeah, but that's gonna be the main thing. So that's what you're like. I could easily see you guys having a question where like you get something that looks like this, and then it's like, what's your education or what's your action? And maybe the answer is like flush the coffee or flush the caffeine. Get a lot of fluids.
It's
But yeah, typically again, typically asymptomatic. Very rarely needs treatment. But if this person's having consistent stuff, then it can lead to that stress. Remember, the SVT can be caused by stress, hypoxia. So if you have consistent PACs to that point, it can cause SVT or it can cause the AFib. Like I think Josh mentioned that too. Yeah, he had mentioned it too. So good shit. And then there's the PVCs. So let me get you guys a picture of that. Let's see. Is this a good picture? I sure hope so. So, and I think this picture also kind of shows one of the weird quirks with the PVCs. So, a definition of the premature ventricular complex, similar to the other one, you have an early discharge, but this one is uh, particularly a the QRS, I believe by itself, right? Right, Caitlin?
come at me again.
Yeah, it's just the QRS occurs just by itself.
Yes,
Yeah, without the P.
without a P due to some irritability.
Yeah, which is why checking for a P before every QRS is something that you assess. He does not. Let me just tell you that.
Oh, that's too much, girl.
Yeah.
Mm-mm.
If you have Professor Beckerleg, she gave us like little like homework where it's like here, figure out all these rhythms, and then in the little homework rhythms that she gave us, there was like I think there was a quadrigemini in there. Um, but yeah, one of the weird quirks with this one is that the PVC, it's gonna be wide, like we mentioned. The wide QRS kind of shows that it's a sign that there's something off with the ventricles, which makes sense if this is a PVC, the ventricular complex. But the strange thing is that sometimes the QRS can actually be upright or inverted. So here we see that the inverted ones. So here I think we see here QRS, T wave, and then PVC, and it's inverted. It's going down instead of going up. And then the T wave goes the opposite direction of the QRS. And the QRS can be upright as well. So if we do, sorry, if the PVC QRS is upright, then the T wave will be upside down instead. So that's like a weird little quirk about it. But yeah, you can see here P wave, QRS, T wave, PVC, T wave. So we see inverted QRS, and then the T wave in the opposite direction. And if this PVC was going upright, then the T wave will be upside down instead. I have another picture. Let me see if that one shows more stuff here. Yeah, this one shows here P wave, QRS, T wave, PVC going upright, and then the T is going upside down,
Opposite.
so the opposite way. So that's an interesting quirk uh, that can help you differentiate. And there is more information if you want to. So there is such thing as the Gemini. There's ventricular bigemini, trigemini, quadrigemini, which is essentially how often it's happening. So if you have, yeah, you don't need to know it, but if you for some reason want to know it, um, the only thing I think is good to know about the PVC that's not already been mentioned is that it can turn into VTAC. Yeah, because you can imagine if you can already kind of look at it from here, just look at this. If you had a bunch of these happening all at once, you can kind of start to already see the tombstone shape start to form. So multiple PVCs in a row can turn into VTAC. And from my own research, oh yeah, more than 5,000 PVC in 24 hours and beta blockers. Cool. I think from my own research, I wrote 3+ PVCs in a row can be considered a non-sustained VTAC. Because remember, the non-sustained means that it's not always tombstone. It goes tombstone, then it kind of comes back, then tombstone again. So 3 or more PVCs in a row can be considered non-sustained VTAC, but that's a little extra. The only thing you really need to know is that this can become a VTAC, which hopefully I hope makes sense that if you have premature ventricular stuff, it leads to VTAC. I think that's the only real thing here. And then with your interventions, if you're fast and symptomatic, what do? That's assess and treat cause. But then if you're fast and symptomatic, what do we do?
Ah,
This is to check if you guys are awake.
I'm barely awake. Does that count?
Fellas, not a trick question.
Was it?
Yeah, synchronized cardio version. And then we have 2 more, assuming there's no questions on this. I'm gonna uh go to the bathroom real quick. Caitlin, can you take over?
Sure.
Yeah. All right,
Okay,
I'll
I
be back.
hope everyone knows what asystole is. Y'all took your BLS for a reason. We love that. Asystole just means there ain't no electrical conduction occurring and there's no mechanical or movement of the ventricles at this point. So it essentially looks like a flat line. It could have like a little tiny bit of waviness, like ever so slight. I don't know where he's getting these pictures from, so I can't put a picture in yet. Oh, I have access to this. I forgot. Hello. Um, so what do we do for our patients in asystole? What can we do for them? Are we gonna shock them? Are we gonna give them meds first? What are we gonna do? CPR, no electrical activity. CPR, CPR, CPR. Where am I? Here I am. So we can do CPR, epinephrine every 3 to 5 minutes, FIV push. Uh, is there a max on how many times we could do epinephrine? Nope, just keep going. I mean, yeah, not really. There's no definitive max. I think once they get to a certain point of going through a certain amount of rounds of CPR and it's kind of determined this person's not coming back, you kind of just stop. Let's see. We can hook the defibrillator to check to assess the was it to assess electrical activity if there is any. Is that what you're referring to? If rhythm returns, yeah. So that's why you're doing your rhythm checks as well. So your 2 minutes of CPR. I believe that's about 5 cycles if I remember correctly. Followed up by a pulse check, and that's a good thing. You can also connect that defibrillator up to check, and if it does go into another rhythm, like maybe it's a shockable rhythm, then by all means. And definitely when we're giving a lot of epinephrine, one thing to consider is that the heart rate could be going up, right? Because we know from our, well, first week, they didn't go too far into it. I believe you guys went over it a little bit more this week. Your epinephrine can be used as a press. Oh, he's back.
Yeah, I'm back.
Can be used to raise blood pressure, but it's mainly affects the heart rate. So depending on how many rounds of epinephrine you're giving, you might end up with return of spontaneous circulation, your ROSC, and they might end up having a really high heart rate after. So just something to be cautious of if they were to obtain ROSC and you see their heart rate is like 110, 120, but I gave them 7 rounds of epi. I kind of expected that, you know? You get me? You didn't like the way I wrote it.
Well, I have my own like uh way of writing it that I handcrafted for.
He said, "Zero waste sucks." Okay, shoot.
So just 1 milligram epi ASAP
I'll
uh
remember this.
every 3 to 5 minutes, and then 2 minutes CPR, and then repeat. Do your checks for rhythm checks, and then hopefully there is return of spontaneous rhythm, or you change them into a shockable rhythm or something, so you can kind of work through that. Pretty self-explanatory. The only thing I would say to note is that even though it's called a flat line, it doesn't. Oh, it can have like a little twinge or
I
two.
already said that.
Oh, perfect.
I just couldn't, I didn't know where you're getting the pictures from, so I couldn't put a picture in there of the slight waviness.
I see. I see. I see. Awesome. And then lastly, there's PEA, which is essentially the exact same interventions. But what is the definition of pulseless electrical activity?
Where'd my chat go? Oh, there it is. I'll give you guys a hint. It's pulseless and it's electrical activity.
Yeah, I just kind of figure you guys are tired too.
It literally, I mean, essentially, it's
Yeah,
right in the name, right? It's
basically,
pulseless electrical activity. You see electrical conduction, but there ain't no pulse.
yeah, pretty much just any rhythm other than VTAC or BFib without a pulse.
That's why it's especially important to check your patient because you might be sitting there, at the monitors looking at it. Oh, they're in normal sinus rhythm, heart rate 70 something. They're beautiful. And then you walk in the room and they don't have a pulse. Ooh, that would be my kind of luck. That would genuinely be my kind of luck. So always check your patients too. Always assess your patients. Do you have enough information to determine is this patient actually safe? Or are they just silently dead, but electrical activity is still happening?
All right. Any questions on any rhythms? Otherwise, we'll go into the stress test, which isn't too much that you really
Oh, I
have
forgot
to,
the stress test was here.
not too much that you really have to go over. This one, I think we'll just make it easier so we can just move on to the questions because I know you guys are tired. So I just kind of wrote down a list of indications for why someone might want to get a stress test, and all of these I know that if it were to come up on a test, you would see it and be like, that makes sense. uh, angina, acute chest pain, someone that had a recent acute coronary syndrome. Don't know what CHD was. Let's see, CHD.
I
Oh, chronic heart disease. That makes
was like, I don't know what you wrote there.
or
Oh, but you
congenital,
had your
yeah,
own
heart
way of
disease.
writing it, didn't you? Your own way. I'm gonna be shady. Don't think I won't.
It's okay.
I'm gonna stay shady.
Congenital heart disease. Uh, pretty much if it's like something heart stuff. That's how I think of it. Heart stuff.
If you want to see if the heart is working correctly, you could do a stress test.
Yeah, basically. It's enough that it's that you'll be able to tell. Um, that it's like one of the indications. I guess the main thing is maybe consider um when would you not want to do a stress test? So can you guys write down some examples of when do you think the person does not want to have a stress test? Anything else? For copy paste this big list. It's not a trick question. If patient's having an MI, no worries. If patient's having an MI, do you want to do a stress test?
My boy Josh, you're always working.
You
I
are
always
always
feel so
working.
bad. I always feel bad.
Basically, if they're hemodynamically unstable, uh, they've got unstable angina, acute MI, hemodynamic aortic dissection. This guy's dying.
God.
Uh, essentially, if they are actively hemodynamically unstable, we don't put them under more stress. It doesn't make sense. Here, I guess this one's more like they've had symptoms of angina, but they're stabilized.
People angina.
Yeah. I guess recent acute chest pain. I guess this one's kind of weird because this is from the notes, I believe. But yeah, for the most part, I would say as long as they look like they're hemodynamically stable, they can have a stress test.
Pretty
You
much.
don't have to worry much about the stress agent or the imaging agent much, but here it is just for your own information.
Most of the time in the hospital, you're not going to see the treadmill
True.
of that patient. My mommy schedules those.
I've seen the regadenoson, it's a adenosine agonist, so which is interesting because adenosine we think of it like stopping the heart, but in this case it's causing stress or causing essentially like the feeling like you're working out because apparently I looked this up because I was like, why does that work? It's just the difference in it's crazy the difference in dose and the speed of infusion have on the effect on the body. So when you slam it, it causes the heart to stop and then restart, and then when it's given more slowly at different doses over time, it can cause basically not I wouldn't say the opposite effect, but it causes like that's stress on the heart. So it makes it work harder, makes the heart rate makes it like as if they were working out. This is interesting.
Yeah, I think that's pretty much it for it.
Yeah, that's pretty much it. Any questions? Otherwise, we will move on to to the questions.
No, we're gonna go to the heart poem. Scroll
Oh,
down.
the heart poem, heart poem.
Yeah, all the way,
Where
all the way,
all the
all the
way?
way,
So
all the way.
they're gonna see the answers?
Just go real quick. Just go. Yeah,
Okay,
there you
cool.
go. All right, so here's the little heart block poem, which I found after 240, and I kick myself in the butt every time. Dobutamine does help with contractility,
Yes, it
so
does.
That's part of your cardiogenic shock. That's a treatment modality, putting them on a dopamine trip.
Hmm? It's a ionotropic medication.
Positive inotropics.
Positive ionotropic. Yeah.
Yeah, so the heart block poem. So if the R is far from the P, then you have a first degree, aka it's long. And then into our type 2s, longer, longer, longer drop, then you have a Winkelbach. Makes sense. And then if some P's don't get through, then you have a Mobitz 2. That's referring to we just have a constant PR interval, and then we have a P wave with no QRS. So that P did not get through. And then if P's and Q's don't agree, then you have a third degree. So our P wave and our QRS complex does not line up at all. So our atria is not going alongside in time with our ventricles. So our P's and our Q's are not agreeing. That's the worst type of block. Your AV node is completely blocked off. There's no communication.
They're
I like it
divorced.
too, Josh. I wish I found this before 240.
Yeah, the
I'm very upset at myself for this.
in third degree, the P and the Q are divorced, and you're the child that's
Oh my
dealing with the.
God, dude, that's too dark. But yeah, so that will be at the bottom of the outline for you guys. At this point, now we could go back to the questions. I think I have 10 or 11 for you guys. Not too many today. Oh, it's tiny. I can't see it. Okay, there it is. So number one, you obtain an ECG or EKG either or on a patient and the rhythm is sinus Brady with a rate of 52. Your next nursing action is to do what? Oh, I almost closed myself out of the Zoom.
Bruh.
Oops. I was trying to move the chat to like the side. Definitely so, right? Always check your patient first.
Mm-hmm.
Do I have enough information? I know their sinus Brady. I know their heart rate. My kind of luck, this would be a PEA, but yeah. Are they symptomatic? Is this normal for them? Is their heart rate so low to the point that they're now becoming hemodynamically unstable because their cardiac output, which is our stroke volume times our heart rate's too low, so our cardiac output goes down the drain. So definitely we need to go in and assess this patient, and our intervention from there will be determined from that assessment. If
Imagine they're
they're
just
hemo,
sleeping.
well, then he's fine. No treatment, just document it. You
Yeah.
know? But yeah, definitely assess your patient first. Cool beans.
Cool beans.
On to the second one. So the nurse watching cardiac monitor notices that the rhythm suddenly changes. There are no P waves, the QRS complexes are wide, and the ventricular rate is regular but over 100. The nurse determines that the client is experiencing which of the following dysrhythmias? The little scroll wheel thing that's on my mouse, it's starting to squeak. So I was scrolling down, I heard squeak, squeak,
Squeak,
squeak.
squeak, squeak. The rats are there.
All right. Yeah, so definitely understand how to read the EK itself, but also understand if they were to ask you in this kind of form to interpret based off of information like the QRS complexes are wide, ventricular rates regular, make sure that you're able to understand it in this shape as well. Able to visually recognize it and then recognize it based off the information you're given. I didn't talk about it yet. We
Hmm?
didn't go over the answer yet. I was just mentioning
Oh.
something. This man ain't paying attention. I know him. Is there anyone else that wants to put an answer choice in? First, you tell me my writing's not good enough, and then you try to go over and skip my questions.
No.
Yeah, wrong. But yeah, so this is VTAC. We can tell mainly just because it says our QRS complexes are wide. So that's that tombstone looking thing, right? Cool beans. Okay, now you can scroll down. Me. Okay, now he's being petty. Okay. I knew it. I was like, I knew you heard me. Okay, so number 3, a nurse notes that a client with sinus rhythm has a premature ventricular contraction or a PVC that falls on the T wave of the preceding beat. The client's rhythm suddenly changes R-NAR to one with no P waves, no definable QRS complexes, and coarse wavy lines of varying amplitude. How do you interpret this rhythm? I need to come up with a better setup for my computer. My shoulder hurts because I have to like reach for my mouse. Gotta have a better setup.
So we have no P waves, no definable QRS, coarse wavy lines of varying amplitude.
Anyone else want to take a shot at it? It's okay if not. I feel a little brain dead too.
I was born that way.
Oh my God. All right, we're just gonna skip over that comment. I'm worried about you, man. Okay, yeah. So this is C, our ventricular fibrillation. Um, we see that there's no P wave, so I have no atrial contraction, no QRS, so there's no ventricular contraction. Instead, I have these coarse, wavy lines. So it's basically just attempting to have a full contraction, but it's not doing a good job. This is an asystole because I could see coarse, wavy lines. Where it gets kind of confusing is when you have that fine V-fib, where you can have slightly little lines and they look just like a systole. This isn't atrial fibrillation because our atrial fibrillation, we still have QRS complexes. And then our VTAC is very wide QRS complexes. So we're able to knock some of these out right off the bat just because I could see no definable QRS complexes. So the answer for that one was ventricular fibrillation. Beans, guys.
Nice.
On to number 4. Oh, look, an AV block, yay. The nurse is observing the monitor of a patient with a first-degree AV block. The nurse is aware that which of the following characterizes this block?
Bro, did you make everything C?
No, I did not. I did not. I did
Bro,
not.
the last four have been C.
Okay. And your point? It makes you question yourself, huh? It makes you question, like, is it really C again? Or is it A this time? Or is it B? I don't know, man. I'm just trying to throw some variability in here, man. Leave me be.
Say so.
Why is he so mean? So mean. I'm okay with it. Ah, okay, well, much to your dismay, the answer for this one is C. So we have that delayed conduction with a prolonged PR interval. So it'll be greater than 0.20 seconds, or what is that? 5 little boxes. 5 little boxes? Am I adding that right?
Wait, what did you say again?
0.2 is 5 little boxes?
Yes.
Okay, cool. I was trying to count with my fingers. I was like, I think that's 5. But yeah, so it's C again. Sorry. On to number 5 then. Shady. So shady. Number 5, a patient has a persistent 3rd-degree heart block and has had several periods of syncope. Oh, that's great. What priority treatment should the nurse anticipate for this patient? Is everyone else asleep? Two good answers. What did she mean? Anyone else? It's okay. Is there anyone else? That's okay. We'll get through these quick. We'll be out before 7, I promise. So number 5, with that persistent third degree, and this patient is very clearly symptomatic as they have experienced several periods of syncope. For this kind of patient, we know that they need a permanent pacemaker. Their heart rate with the third degree will be very low. It will definitely be below 60, probably also below 50, possibly below 40. Who knows? Could be really bad. So the cardiac output is not good. So I need to get their heart rate back up. There's a couple different ways I can do that. So it's not inherently wrong, quote unquote, for, epinephrine. Epinephrine does raise our heart rate, but that's not going to fix my problem. The fact of the matter is there's a giant block in the road and that signal's not going to get through. So that's just a band-aid on a bleeding wound. I need to fix it. So with this, a permanent pacemaker will be able to keep their heart rate at a sustained rate. The implantable cardioverter defibrillator, that's going to be more for your shockable rhythms to cardiovert them back to normal sinus, as opposed to pacemaker, we're pacing the heart for them. So answer for this one's A. It's not C this time. Diego.
Wow.
Wow. Yeah, I know. Okay. I'm just being shady still. Number 6. Yeah. Nursing implications for a patient with ventricular tachycardia who is awake and alert with a palpable pulse include what? I know. As soon as I scrolled down and I saw the question, I bit my tongue on that one. Like, oops, my bad. We just love C, don't we?
Yeah, I guess so.
I do. All right, so number 6. C's get degree. That is the spirit, Ryan. That is the absolute spirit. As long as you pass, it's all right. Yeah, so number 6 is B and C. So if your patient is unstable, you want to cardiovert them. But like I said, if you walk into my room and you say, "Hi, my name is Ryan. I'm your nurse today, and I'm going to shock you with
Hi,
like
I'm Paul.
120 joules." I will just say, "Knock me out first, punch me or give me sedation." So please sedate your patient if they are awake. So for this one, they are awake and alert. Obviously, if your patient is unconscious, I don't have to knock them out. They're already knocked out. So I don't have to have any kind of sedation. So your sedation, synchronized cardioversion as well, and then your IV antidysrhythmic. So amio was noted here. Let's see. If patient is stable, IV amiodarone used to suppress abnormal ventricular rhythm before considering cardioversion. You could always try that before going into your cardioversion medication before. Cool beans.
Q.
Number 7, patient's bradycardic, pale, short of breath. The nurse anticipates an order for what?
Bro, I swear you've had this question before. Let me see.
No. Oh, I
Not really.
did.
Well, not really, because that one, and that one you assess, but
Well, okay, you just highlighted the answer, so I guess we'll go over it. Shady. Okay, yeah. But so they're bradycardic, they're pale, short of breath. We can tell that they are not stable. They're hemodynamically unstable. So at this point, I think I have enough assessment to make an intervention. I would hope that you're not giving them a beta blocker because I don't want to slow their heart down more. So following your bradycardia algorithm, you're going to be giving atropine. So is there anything else I was going to put here? First line medication, it blocks the blah, blah, blah. Just know it's your first line medication. It's going to be the first thing you're going to do for your symptomatic bradycardia. Oh, what
Noise.
happened with number 8? How weird. Okay. So the nurse sees the following rhythm on the monitor. Which of the following lab values could have caused this dysrhythmia or is most likely to have caused it?
So it's time to analyze this rhythm and then be like,
Yay.
wee.
Well, I guess the first question is what rhythm is this?
Sure. What rhythm is this?
Just sinus tachy? Yeah, so just
Yeah.
sinus tachy. Now with the where am I at? Number 8. So when your potassium's that low, that 3.0, we're going to be seeing different types of changes. We're going to be seeing that what's it called? Tall peaked T wave, which we do not see present here. For
Bruh.
sinus tachy,
Oh,
what'd you
never
say?
mind.
No, you was gonna say something.
No, it's just like you put hemoglobin. Yeah. It's not even an electrolyte.
You know what? It's been a long day. I'm sorry. I should have said which lab value. Forgive me. I'm struggling here. But in any case, that is the answer. I should probably put a lower value, but a hemoglobin of 9, this patient is technically anemic, which can lead to our sinus tachy, because as we remember from 220, yay, 220, or I think it was also brought up in 232 as well. When you have anemia, there's not enough blood, there's not enough oxygen transport around the body, so your heart has to work harder and faster to be able to keep up with body demand. So that's why your heart rate's going to go up when you have anemia. So because this is just a basic sinus tachy, your anemia could be causing this. So hemoglobin of 9 is suspicious. Excuse me while I just put lab value and not electrolyte. Forgive me. No, I said which of the following lab
Oh,
values.
you
It says
did.
right there. Oh, you got me messed up.
Yeah. So all you guys in the chat got tricked. Boom.
Sorry. I'm sorry.
They didn't think you had it in you, but you did it to them.
And look at that. It was another C answer.
Yeah.
Why is everything C? Did I seriously do this? Okay,
Yeah,
no,
you,
no, no. I didn't. I didn't.
dude,
It's okay.
there's like one or two that weren't C.
Okay, well, you know what? All right, so number 9, the nurse has just administered adenosine via IV push and sees the following rhythm on the monitor. What is your priority intervention?
Don't just look at the rhythm. Look at the context.
Bro, my shoulder hurts. How much does a massage cost?
So let's zoom in on this pulse real quick. Or this what is the rhythm shown here?
I think they know. Well, it could be technically. It could be. It's very hard to differentiate.
It is very hard to differentiate.
But then looking at the context of the question as well.
Yeah, so look at the context of the question.
Oh, it's okay, Brianna. Don't worry.
Don't
It'd
worry.
be like that sometimes. So, right, we just gave IV push of adenosine. So I have a horrible way to remember this. When you're giving adenosine, I always thought the D in adenosine meant die. Um, I don't know if that helps, but that helped me for some reason. And it still sticks in my head. It stops the heart. So this is actually an expected finding. Now, if it goes on for like 20 seconds, now now this ain't so expected. But if I see this, it should only last a very short period of time before we start into another rhythm. Hopefully start into another rhythm. So at this point, this is expected, so technically document findings and continue to monitor is correct. Now, if they don't come back, then we're going to do chest compressions. So just be cautious with that. Adenosine, seeing a flat line after pushing adenosine is not, it's not unexpected. We expect this to happen. Beans. Any questions on that?
Yeah, Ashley says, how long does it last?
Oh shoot, sorry. I'm trying to remember. I only saw it once. It lasted, I would say, like 5 seconds, but let me look up exactly how long it could last. That is something that I don't entirely know right offhand.
Yeah. So again, just keep in so yeah, we know that fine B-fib and asystole can look similar, and you can have again asystole with some like very slight movement, but just keep in mind the fine B-fib, it's going to be very multiple like fibrillations. Well, asystole is going to be mostly flatline, but again, it can have like you can see this slight like
It
moving
looks like
pattern.
titling.
Yeah, and it can have like you might have like maybe like one uh hill looking kind of thing. But with the fine B-fib, it is like fibrillating, like actually fibrillating. So try not to get confused by that.
So I see a couple different answers for how long asystole lasts after pushing adenosine. I see a study saying asystole can last 8 to 10 seconds if the dose is between 6 to 90. I saw another one where if you're pushing 18 to 45, it could last up to 20. Ooh, that's a fear. So it could actually last quite a while. I was saying 20 for a reason. I was trying to figure out why I said 20 seconds. That might have been why. I must have seen that study before. So it could actually last quite a while. On the instance that I saw, it only lasted about 5 seconds. It was very quick.
Yeah,
Um, but I guess this is going to depend on individual
yeah.
reaction. I
It
don't have as
says
much experience with seeing it as I had only seen it one time.
seems like it typically is less than 5 seconds, but I guess it depends on the personals.
That'll be my kind of luck. Annie, are you okay? No, I just accidentally killed Annie. Sorry.
Okay.
Full beans. So number 10, you, the nurse, note the following rhythm on your EKG monitor for a patient named Jerry. Hi, Jerry. He is
Where's Tom?
hemodynamically stable. What is the first thing the nurse should do? Oh, yeah, definitely always identify your rhythm first. So we're looking at SVT. I have a stuffed animal named Jerry.
Jerry.
Yeah, he's a giraffe, and he has like the little bags inside him you could take out and microwave. So he's like a weighted stuffed animal with little heating packs inside. I love him. He's my favorite.
Maxwell's your favorite.
Maxwell is my favorite, actually. I took good care of that stuffed animal, okay? I had Maxwell since I was 2. This little stuffed dog. So I had to think about how old I am right now. I was like, wait, how old am I? So 22 years later, and I still have Maxwell. It's
Wow.
been a long day. I looked down at the year and I almost said I was 25 because the year usually goes with my age after it gets to a certain point in the year, of course. But
No, she's
I'm
24.
24. I had Maxwell since I was 2. But trust me, I still definitely feel like one. Physically, I feel like I'm 60 though. My knees kind of crack. I get up wrong, it's over. My hips like to pop a lot. My back's in pain. So maybe physically not so much, but mentally I still feel like a child sometimes. Definitely so. I wonder if that's something I'll ever grow out of. Probably not. It's okay. Same. Okay, y'all. We just have this and one more, and I told y'all I was gonna get y'all out by 7, and I totally forgot about that. So,
Wow.
for number 10, this is B. We're going to tell Jerry to take the fattest poop of his life. He is stable, he's alert, he's chillin', he's big chillin', so I can attempt to convert him back to a normal sinus rhythm. via vagal maneuver, so bearing down, trying to tell him to take a poop, having him blow into a straw or something that has resistance, like that won't let him blow into it, like the syringe as well. These are all interventions that we could do to induce a vagal response and get the heart rate down. So tell him to take a poop.
It's about to poop his pants, or you're gonna have to change him.
Oh, that would be my kind of luck. All right, and then our last one's number 11. So a nurse, ooh, UAP will. Oh no. So number 11, you are a nurse working in a CVT unit, receiving a report from day shift. After receiving your report, which patient should you see first? Because we love a little bit of priority. Y'all thought it was over. It's never over.
Wow, I applaud you. Um you did two non-Cs in a row.
Thanks. I know I tried so hard. You're just being shady now too. All right, yeah, so just we'll just get through this real quick. So number 11, it is going to be B. So first looking at A, our 23-year-old professional tennis player, aka he's way more fit than I am. With a heart rate of 47, this is expected. B could definitely be a clot, right? So we have a 69-year-old AFib who all of a sudden is now confused. This could be stroke. So you're looking for your B fast, so just keep in mind B fast. C, a flutter who's feeling unusually tired today and yesterday, man, you're fine. And D, someone with sinus tach who is asking for her at-home metoprolol. This is not going to really do too much. They're in a more stable rhythm and a more stable state than our 69-year-old dude with AFib. So yeah. The
Cool.
last things I have on here are kind of memes, high key. I have a CPR playlist and Don't Drop the Beat, 150 songs, and they are both AHA certified. The
Wow.
150 songs on Spotify made a playlist, or not Spotify, excuse me. AHA made a playlist on Spotify going over this stuff.
Getting jiggy with it.
Under pressure. Push it. Yeah, I'll be under pressure, all right? I'm just sitting there like the family members are watching me. Just a girl. Oh, wow, I'm just a girl.
That's
But
funny.
yeah, so there's a whole bunch of songs. So if in the odd event that you do have to do CPR at one point in your time as a nurse or in nursing school, um, just some songs to keep in mind. Cool beans. And that is all that I have for y'all today. Is there anything else you need to go over, Diego?
Nope.
Cool.
You guys are doing good. You guys will do good. Remember, it's not a 4x4 sterile gauze. Um, uh, da, 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 da.
You're so salty.
Yeah.
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 I mean, right? Like, we don't want a gauze on it.
Yeah.
I was like, you really shouldn't have anything. Yeah, you want to see it. I want to see if it's infected or bleeding or if it's, pulled out or pushed back in too far. Your gauze isn't going to let you see that. It's not see-through.
Yeah. Transparent,
Yeah,
semi-permeable thingy.
yeah, for your picks as well, because I believe it actually came in